shared insights of the benchmarking already, but we have received quite a few requests from our clients and partners in Asia and Middle East to repeat it, to accommodate especially facilities and organizations that operate in Asia and Middle East. But we very much welcome all other locations whenever you are. I hope you will find it useful. A few housekeeping remarks on the round of the shows. So we'll have opening remark by Shaliza Semgi, who is our regional pre-investment and advisory manager at IFC, covering MCT region. We will have then Raju Narayan sharing actually insights of the 2025 round of benchmarking, and then we will have a discussion of it. And to prepare to make most out of the discussion, please feel free to participate actively, use chat, and most importantly, use Q&A chapter, and then we'll have both our panelists and our speakers to answer all the questions that you have. I guess with no further ado, I would like to pass the floor to Shaliza to share a few opening thoughts. Shaliza, over to you, please.
Thank you so much, Yana. Good morning, good afternoon, good evening, everyone. It's a pleasure to welcome you to today's session on the results of the 2025 IFC Healthcare Benchmarking Round. As many of you know, healthcare delivery in most of the markets we work at is not driven by a single actor, and it's indeed a mix of healthcare systems where the public and private providers operate side by side. Private sector here plays an critical and increasing important role in expanding access to healthcare, addressing capacity constraints in very often overstretched public systems, and in driving innovation in service delivery, in technology adaptation, and in patient experience. At the same time, the private sector providers are also facing increasing pressure to demonstrate value, not only to the patients, but also to payers, regulators, and investors. This means that delivering high quality care and operational efficiency alongside financial sustainability is indeed very much needed. We also realize that one of the biggest constraints that we continue to see across emerging markets pertains to the lack of reliable, comparable performance data. Many healthcare providers are oftentimes operating without a clear understanding of how they efficiently use their resources, how does quality care compare to peers, and where the biggest opportunities for improvement lie. So in that regard, and under this backdrop, we initiated the benchmarking clients in response a benchmarking project in response to several clients' requests for comparing themselves with other facilities in other markets. This benchmarking project is indeed an objective to identify performance improvements across financial, operational, and clinical dimensions. IFC also frequently sees unrealistic projections in our business plans, in clients' business plans. For example, an aspiration to get to a break-even level in year 2, while we know it typically takes 3 to 4 years for the break-even, and in some markets, even longer. Sadly, we also see underutilized and even unutilized high-value assets, much possibly due to uninformed assumptions around realistic workload levels. As a long-term partner, we see that balanced approach is needed to managing performance, clinical excellence, operational efficiency, quality, and patient safety. All of these factors will translate into financial sustainability and ultimately better care for patients. It's very important, therefore, in emerging markets. Today's webinar will share the main findings from this year's benchmarking round. We'll explore what the data reveals about current trends, performance drivers, and areas for growth in the healthcare sector. Lastly, I would like to end my opening remarks by thanking the government of Japan that partnered with us on the Healthcare Benchmarking Initiative allowing for the creation of this valuable knowledge product. I'll pass it over to Yana for sharing the key takeaways for the study for Raju to take over. Thank you so much.
Yeah, Raju, over to you.
Thank
And
you,
Jenny,
Yana.
you can share the slides.
Yeah. Okay,
Can everyone
here
see
we
the
are.
slides?
Yes, we can, Jenny. You can go to the next slide. Okay, so welcome everybody, and thank you all for participating in this webinar and also participating in the benchmarking exercise. This is our second round of full benchmarking exercise which we have done, and my purpose here is to share some overarching insights and observations which we have seen in this round of benchmarking, and get into some details of some of the findings, and then over to the rich pool of panels to have a vibrant discussion, and then over to the participants for a very interactive session. So, as I mentioned, we did this benchmarking. This is a second full round, so we did an interim round in between. And the good thing which we have seen upfront is that 66% of the companies participating in the previous round in 2023 participated again in 2025. And what this tells is basically there is real interest. The participants in the previous round found the information, insights, and the reports useful in one way or other for their own internal comparisons, performance improvement initiatives, and overall management of their healthcare operations. So I think that's a very encouraging sign to stay with. So this time around, we had over 50 companies participating, which means some of them have multiple facilities, some are single facilities. So if you count by the facilities, 180 over hospitals and providers who participated in this, 30 over countries. And most astonishing thing is 40,000 data points. So we looked at financial, operational, quality, and selected clinical parameters. So 40 over 1,000 data points were analyzed, standardized, validated, and then whatever insights which we could come up with them were shared with the participants for them to take on from there. And this is just to give you a quick overview of where the richness of the data which we have collected. Next slide, please. Yeah, so this is just a pictorial representation of the geographical presence of these participants. And these are not just IFC clients. So this benchmarking exercise is open to anyone, any healthcare provider who is willing to participate. And that's a key thing to note. It's not meant for IFC clients alone. So I think that makes the data set very rich and very useful for participants across the globe. And we hope to see this changing to a more colorful kind of representation in the future rounds. Next slide, please. So I will just take next 10-15 minutes to just set the context and to give a high-level overview of why benchmarking, why did IFC initiate this, and some of the findings, and how did the participants find this benchmarking exercise. And you will all know that people who are working in the emerging markets know that there is a great push and aspiration for universal health coverage to be achieved. And this could mean different things to different geographies. Universal health coverage is in different level of maturity and sophistication across the globe when you look at it. And the fundamental reason for universal health coverage doesn't matter which geography you are. One thing is to increase overall access to care and increasing the efficiency of the funding, because there is no indefinite pool of money available to any government. Doesn't matter whether it's a matured country or an emerging market, developed country, whatever it is. There is no indefinite pool. So you got to make the most out of the funds you have available for you to provide that care. And that's where efficiency and productivity comes into play in a very large scale. And the other most important thing, if not the primary thing, is the quality of care, because providing access, providing funding is, I would say, maybe relatively easier. But the thing is, if you do not provide the quality of care, you're actually making the problem worse, right? Because if you do not have funding, if you do not have the access, that is one problem. But then if you have the funding and access, but then if you go to a provider and if you don't get the quality of care, and that is very, very dangerous situation. So I think access, efficiency, quality, and then the overall spending efficiency. So these are the fundamental reasons why universal health coverage is going to be useful and at the same time challenging. So this is just to set the overall context. So now, how does benchmarking or comparison of performance across the globe help this universal health coverage aspirations? Because if you look at private healthcare services across the globe are faced with these challenges: access, efficiency, quality, and clinical outcomes and stuff like that. So what benchmarking kind of helps providers is that how am I doing compared to my peers globally and also regionally? And is there room for me to improve my performance so that I can provide the best care possible in the most affordable cost to the patients and also efficient to the provider as well? So that's where benchmarking comes. And this doesn't mean that this is only useful for private players. At some point, this could also be used for the overall healthcare delivery. As Shalisa mentioned, no country is able to provide care only through one channel. It's a mixed care delivery model, public and private. So this could be useful for the entire spectrum of care delivery providers. Next slide, please. So why did IFC decided to launch this? So this actually came from our clients to begin with. So a lot of our clients, when we invest with them and when we post investment, when we work with them as part of our portfolio management, the question comes to, okay, I'm doing this well. I have a certain, I'm managing and monitoring certain set of indicators for my performance. But the thing is, I don't have visibility of where am I in the bigger spectrum of things. How am I doing compared to my peers in my country or my geography or even globally? Some of the, because IFC's investment, if you look at it again, spread across a wide variety of healthcare providers, depending on the market they operate, right? Some are very matured clients, highly sophisticated providers. Some are at the other end of the spectrum, and a lot of them in between. So the aspirations and objectives of each of these players could be very different. So for a very sophisticated and matured player, they want to know how are they know that they are doing very well within their context or their geography of operation, but then they might want to know for certain parameters, maybe clinical outcomes or quality indicators, how are they doing compared to global average, some of the global players, for them to get to the next level of aspiration. And for some of the other players, they would want to know how are they doing in comparison to their peers in their geography, which could mainly useful for performance improvement, process efficiency, and stuff like that. So that's a fundamental reason the people wanting to get into that. So if you look at some of the highlighted, the geographical isolation, sometimes you are in your geography without having great visibility of how the rest are doing. The other main reason going through an exercise is sometimes it's very important to know what are you comparing with, right? Sometimes you might get some data from other players in different markets, but the thing is the depth of the data or the drivers behind the data may not be visible. It could be publicly available information or through market intelligence or some of the published reports. You might get some data, but the thing is you don't know what you're comparing. So when we did this, most of the work went into standardizing the definition of data. I think that is the most important thing in benchmarking, because just to give an example, even simplest data points like number of beds, which could mean, you might think it's very straightforward, right? But people in the healthcare operation space will know that it could mean different things to different people. If one hospital says I'm a 200 bed facility and another one says I'm a 300 bed facility, are they talking about the same indicator? Maybe or maybe not, because a bed could be different things to different people. Am I counting only inpatient or overnight beds? Am I counting my observation beds in the emergency room? Am I covering pre and post operating beds? Am I counting the dialysis chairs? Is neonatal cribs counted as beds? So all these comes in. So sometimes when you just look at the data in its simplest form. You might think that you are comparing the same thing, so that access to the relevant information, making sure that you are comparing the right indicators. So that is again a crucial thing. And that's, as I mentioned, that was the main chunk of the initial work, is to standardize the definitions. And then sometimes reluctance to share data, because if you approach another provider in your geography or across the globe, sometimes they may not want to share the data because anonymity is a big concern for that. So I think going through this exercise, IFC is very, as World Bank Group, we are very, very committed to making sure that the anonymity of the data is protected and preserved. So I think that gives the participants confidence that, okay, when I share this data, it is going to be anonymized. My business model or the business risk is not compromised. So I think that gives them that confidence. And most importantly, beyond comparing data is to understand the insights and the drivers behind the data. What is driving the data? Why is one organization achieving a certain performance versus another organization in the similar geography? So understanding some of those insights would be very useful for the participants, and they could actually use this for, as I mentioned, performance improvement, resource optimization, etc. Next slide, please. So IFC's motivation, as I mentioned, to summarize, would be to understand the micro level analysis. So we could go into deeper analysis of the data, providing insights, and performance measurement as a practical tool for performance improvement. Because, as they say, you can't manage what you don't monitor and measure. So I think you need to monitor, measure, and understand the drivers behind that, and then get into and put that into context to your own operations, and then look at performance improvement as a next step to that. And of course, most important thing is knowledge sharing. As I said, healthcare is unique in many ways to geographies, but then if you look at the fundamental challenges, they are very common across the globe. And that's an amazing thing to understand. When I look at healthcare operations across the globe, you understand that the challenges are, in one way or other, very common and very similar to company to company. And so you don't have to really reinvent the wheel. So I think that's an advantage. The problem which you're facing today, somebody would have faced it some years back, and they would have found some solutions. And if you could adopt that to your operating geography, you don't need to reinvent the wheel. So I think that richness of data sharing comes into play here. So I think that's one of the encouraging benefits of this exercise, and quality improvement, and again, for, as I mentioned, for clients who has got a multitude of facilities within their own network, both internal benchmarking and external benchmarking comes into play. There are hospital providers with 40 or 70 hospitals, so there's a lot of internal benchmarking that could be happening. But then beyond that, when you compare that with the external benchmarking, you could understand that. And then again, you understand, in an emerging market, there are different models of providers, business models that are happening across various geographies. Because as we mentioned earlier, your patient mix or the payer mix could be very different. There could be certain geographies where there is a high level of penetration of social health insurance or private insurance or cash paying patients. And so how do you work within this mixed payer model? And then what are the nuances of these various models? And then trying to understand the challenges and solutions to get some of these things right. So that again comes in very useful. So these are some of the motivations behind IFC wanting to get into this. And I believe these are the same motivations why participants are eagerly participating in this exercise as well. Next slide, please. So some of the observations, I'm just going to give a very high level overview of the observations without getting into too much detail so that we have more time for discussion. What we saw is a very wide variation in performance. You might think that, okay, this is common sense, right? You are comparing across the globe, and then obviously there's going to be but sometimes when you look at the range of variation, and that's what is interesting. When you look at individual parameters, you might know that yes, there is going to be variation, but then how much? So I think when you quantify that, then it gets more interesting. So when you look at the market nuances, the business model, the service type, access to healthcare, and these are common problems across the globe, but then how each provider functions within these challenging environment, the variation in their performance, the depth of variation and the breadth of variation is very interesting. And then regional variations is again something which we were expecting it, because you might think that, okay, when I look at Asia, Southeast Asia, or Middle East, or Europe, or Africa, regional variations should be there. But the thing is, it wasn't that great a variation. Performance generally is lower than expected. We did expect some variations, but then it wasn't as compelling as global variations when we look at it. And then, as I mentioned, the level of interest were phenomenal. 66% of the participants were repeat participants. And what does it mean is that they could themselves look at how were they performing in 2023 versus 2025 after implementing some of the performance improvements, process efficiencies, learning from the first round. And we could also see that quality of data coming from these participants. And that's a super encouraging factor, because how did they get their activities in order so that their data submission and the data quality. I still remember in the first round of benchmarking when we did, the data validation were a nightmare, because although they were very heavily standardized and defined, the quality of data sometimes when it came in, we had a lot of time we had to spend to validate the data, because if you don't do that, and you're comparing not apple to apple. So I think that validation of the data was very, very crucial. And it only got better as we went along, especially for repeat participants. So the data quality was phenomenal. And the other important thing is we did compare not just from emerging markets, but we also compared the data with internationally available public listed healthcare companies. So I think that gave a very different dimensions to the overall benchmarking exercise as well. Day surgery, and this is a very favorite topic, because you know that everyone across the globe has only got one aspiration. If I want to put it in just one sentence, is that everyone wants good quality care at an affordable price. Doesn't matter whether you are a emerging market or a developed market. This is everyone wants to achieve that, right? Whether it's a patient or the provider or the payer, everyone is aligned in that. They want to give good quality care at an affordable price. And then the question is, so you might think that, okay, that means the one way to do that is how do we bring down the cost of care? So reduce the amount of time a patient has to spend in a hospital. So day surgeries, same-day surgeries could be a solution for that. So that's common sense. But the thing is, we notice that in an emerging market, it's very, very highly underdeveloped because, again, many reasons, right? It could be the skill set to begin with, the clinical skill set available in that market. It could be the behavior of the patients coming into that market. And the other important factor is the payer's behavior itself, because many insurance companies never used to pay for day surgeries because of many reasons. So patients were forced to stay overnight, even if you could have done it by day surgery. But so I think many factors were affecting the penetration of day surgery cases in emerging markets. So we saw that it is very underdeveloped, and there is a great room for improvement in that space there. And the quality indicators, as I mentioned, although the level of submission was improving, but in many instances we saw a kind of indication of underreporting, and that's again because quality reporting also needs cultural change as well. There's a change management needed, because the overall culture of reporting incidents, errors, mistakes, near misses, it has to be nurtured within the organization. So people don't report things, especially near misses. People don't report it because, oh, nothing happened, so I don't need to report it, because if I report it, I could get into trouble. So I think that quality culture and the reporting of incidents and near misses need to be nurtured. So we do see some areas where they were little bit of underreporting that could potentially happen. And then maternity outcomes is something which we piloted this year because there were a lot of requests to look at clinical outcomes and clinical indicators from the first round. So this time around, we started with maternity outcomes. So we did see quite a good pool of data that came from this space, but in many instances they were underdeveloped, and that is something which for us to look at and also for the participants to consider. But I guess as we go along, this should only get better because again, comparing clinical outcomes can also be very interesting and very useful for the providers. Next slide, please. So this is just a quick overview of the kind of indicators which we look at. As Jana and Shalisa mentioned, we looked at financial, operational, clinical, and quality outcomes. So within the financial, this is just a sample. There's much more detailed indicators which we looked at: cost structure, the revenue profile, profitability, pricing, operational, utilization of beds, utilization of key assets, of whether it's imaging or your ICU or operating theaters, and your productivity, your staff to bed ratio, your payer mix. As I mentioned, it could be multiple revenue streams that is coming into the hospital out of pocket versus health insurance, private insurance, and clinical outcomes, day surgery cases, and as well as maternity outcome as a pilot. And then, of course, quality indicators. There is a whole range of quality indicators which we looked at as well. So 148 comparative indicators were used for this round. Next slide, please. So now let me just get into some of the details of how some of these indicators are performing. So remember, I mentioned that there was a variation in some of the indicators when we looked at. So if you look at this between these indicators, if you look at the variations were between 2 times to even 5 times, right? So whether it is utilization. So here, if you look at the utilization of key healthcare facilities, like your operating theaters, your day cases per day case operating theaters, your interventional cardiology cases per cath lab, your deliveries per room, inpatients per bed. If you look at the variations, it's quite significant, 2 times to 5 times. What does it tell you is that one thing is, yes, you could be underutilizing. That means with the existing resources, you could provide care for a much larger number of patients. So that's a very interesting proposition to look at, because sometimes we say that, oh, okay, we need more beds, we need more operating theaters, and this usually is the common. As an healthcare operator managing hospitals over 30 years, one of the key complaints when I get from my users is that we need more operating theaters, we need more beds. But the thing is, are you utilizing your existing facilities correctly? The only way to convince that is look at the data and see how are you doing. And people will say that, yeah, I'm utilizing and I'm running at 60%, 70%. But the thing is that the norm? Can you do better? Or is there, and again, so this is one side of the story, but at the same time, you can't just blindly compare, or somebody else is running their operating theaters at a certain capacity, so I should be able to do the same thing. And that's the biggest mistake you make. So you need to understand what is driving their performance versus my performance. Why is my utilization apparently lower than theirs? So you need to understand the things so that you don't just do some knee-jerk reactions to either increase your utilization or to increase your resources, but you study the data and then come to an informed decision as to what I could do. So that variation, quantifying the variation is a very interesting phenomena which we have seen. Next slide, please. So this again, look at variations in the utilization of high-cost equipment. So everybody, and this equipment is again, when you work with healthcare operators, you understand that even patients ask for certain equipment nowadays, right? Patients want to know how many slice CT machine you have, what is your specifications of your MRI machine. Do we have a robotic machine that is doing the surgery? Because people read up today's sort of information available. So So you invest in high cost equipment that has become a norm nowadays, and now the question is, how much are you utilizing these equipments? Am I utilizing it correctly, or do I need to uh, purchase the second MRI machine or the second PET-CT machine? So that utilization of the high cost equipment, again, we see wide variations in that. And again, you got to, as I mentioned, a key thing is to understand the reasons behind variations in the utilization as well. You might see that there is, because, and this is where an interesting point I would want to mention here is the dependencies of indicators is very, very crucial, right? Because just to give you a very quick example without going into much detail is, you might see that this particular hospital, their number of scans per X-ray machines is at a certain number, much higher than mine. So you might be wondering, why is that so? Maybe you got to look at more detail as to why is that, because maybe they only have one machine centrally located, so everybody utilizes the machine. All the outpatient utilizes the same machine, health screening people utilize the machine, inpatients utilize the machine, so the utilization per machine is very high. But the thing is there some other indicators that is being affected? Maybe if you look at the waiting time for scans, maybe is very high too, because patient needs to wait longer, which could affect your patient experience and patient satisfaction. So that's something which for you to consider. Somebody else might be doing slightly less utilization of their X-ray machine, maybe because they have 3 X-ray machines decentralized. They have one for the outpatient, dedicated for the outpatient, one maybe for the health screening, because they have a large pool of health screening preventive care patients coming in, and then they have a pool of inpatients who are utilizing that. So they kind of decentralize. So the number of scans per machine might be lower, but then the overall patient satisfaction and their patient mix could be very different, right? So that's why I said you need to understand the interdependencies of these indicators before jumping into conclusion and driving utilization blindly. So understand the drivers behind these indicators is very crucial too. So that's why this variations is one thing, but understanding what drives this variation is very, very crucial. Next slide. So again, if you look at the other important thing is when you look at, and when we looked at the profile of the participants, again, you see a wide variation. There are, as I mentioned, matured players, meaning stabilized operations of more than 5 years, and then less than 5 years are new in their ramping up phase of their healthcare delivery. So again, when you look at the performance of these two groups, you can see the room for improvement, and the good thing is that you could, so you're not blindly waiting that, okay, come 6th year onwards I should do better. It's not just a faith alone, there's a data that is driving that too. So you can understand that, yes, generally across the globe, when you look at it, the operational performance of matured players, which is more than 5 years, is much better than somebody who's just ramping up phase. So this is another interesting find which we have seen, and this also kind of validates with our experience when we look at investments and everything, that as I think Shalisa mentioned, that sometimes when you put up a greenfield hospital, we have seen unrealistic aspirational projections that, okay, I want to EBITDA break even in year 1 or year 2. It is maybe possible in some rare occasions, depending again on the nature of operation. But mostly it takes 3 to 4 years for the hospital to get into a stable space. And again, the data kind of validates that observation here. Next slide, please. This is again, as I mentioned, regional variations. And the good thing for this crowd, who's that, I think, I don't know the participants' profile of today's webinar. So I think if you have more people from Asia and the Middle East, just give yourself a pat on the shoulder, because you can see that the regional variation, the operational performance of generally the Asia and Middle East, North Africa, seems relatively better than some of the other regions which were participated in. Again, as I said, this is a good observation, but of course we need to understand what is driving this individual regional performance, and what are the nuances behind these regional variations need to be understood as well. Next slide. And so if you remember, I mentioned that we did not just compare the data with the participants of this exercise. We also compared the data with internationally publicly listed companies as well. So if you look at, and this is just one example of one of the indicators, is that it's very there are variations, but comparable. And so if you look at average receivable days, publicly listed companies 59 days versus 70 days. This might look like a simple indicators, but I think there's a lot of underlying factors that is driving this. Again, in emerging market, as I mentioned, there is a spectrum of, there's a variety of payer mix that happens. People and the percentage varies from hospital to hospital, region to region. There could be patients coming in through social health insurance, private insurance, or out-of-pocket payment. So if you have a large pool of patients coming from the social health insurance, the receivable days of the payments is a crucial thing for the provider, because if you take in those patients, if you don't get paid on time compared to patients who's paying by out of pocket, that could affect your working capital and your liquidity concern. So this is something to consider. And of course, there are good examples of regions which our panelists will share, that even with a very high penetration of social health insurance, the receivable days were very manageable and able to provide care. And this is where sometimes this data becomes even more useful for not just the provider, even for the governments to look at, right? Because when you want to encourage private providers to come into the social health insurance provision empanelment, this is where the government also needs to play their part. That, okay, that means you're going to get paid on time, because if you don't get paid on time, how am I going to sustain my business operation? So this is where the data comparison comes in, and say that there are certain regions are doing it better, so how can we do it? So this is where the contracting of public and private facilities all could use this kind of data much more usefully and efficiently. Again, a very, very powerful data set to look at. Next slide, please. Yeah, so this again, so if you look at the various payer mix, out of pocket versus private health insurance, social health insurance, so you can see the variation there, right? From 41 days to 110 days. And what does this mean? Is if I'm a single provider providing social health insurance patient, if I'm only going to get paid 110 days later on an average, how am I going to sustain my operation? So this is a very important indication. And as I said, there are regions where social health insurance payments are so much better than this. So this is something to learn and to understand and to implement as well. Next slide. Staff turnover, one of our favorite topics. So this again, when you look at it, everyone talks about this emerging market, developed market, whichever market you look at it, staff turnover rate. Again, you see a huge wide variation. It could, and again, depending on the type of staff you're referring to, the variations can be very different too. Everyone knows there's a huge shortage of healthcare professionals across the globe. And so this transition and this brain drain or brain train, whatever you call it, patients and the staff, whether it is your clinical staff or your nursing staff or your paramedical staff, they keep moving around. And so this is a huge concern for healthcare providers across the globe. The thing is, what can you do about it? And again, a lot of lessons to be learned. And I get often asked this question of, how do I prevent my doctors, my nurses from leaving the hospital? As a hospital CEO, my comment to my team has always been that you can never let your doctors or nurses leave the organization for the right reasons. Let me explain what it is very quickly. People leave for different reasons, right? So what are the right reasons doctors want to leave your organization and join your competitor or leave the country? Is that, oh, the other entity is providing a better infrastructure? That's a right reason. The other entity has got a good support system, good set of nurses, highly qualified nurses. Again, a right reason. The other entity is well managed and well run facility with good use of technology, right kind of machines and everything. these are the right reasons. You can never let your doctors leave for those reasons. These are the right reasons. But of course, if somebody tells you that I want to leave because I can do whatever I want in the next facility, nobody questions my clinical sovereignty, I'm the boss, I can do it, and I get paid much more, and I can charge whatever I want. These are not so the right reasons to leave, and you can't stop that. So people are leaving for the right reason. That's something for you to look at internally. Why is that so? Can I make it better? Why is my support system? If the doctor is saying that I'm leaving because your nursing team, the quality of a nursing team and your supporting team for pre and post-op care is not optimal, so I can't risk my patient's outcome with the organization, so I want to leave. So, and there is something for you to look at, and how can I do that? Same with nurses. Why am I leaving? Because maybe I'm not recognized and respected well within the organization. So maybe by the empowerment of the nurses is not, and a lot of nurses leave one country to another country for that reason, because some of the developed market, the nurses are placed at a very different level compared to some of the emerging markets. So they go for that professional recognition and empowerment. So that could be the reason. So these are, so just instead of just looking at the data and reacting to it, trying to understand the reasons behind this, and then look at, and there are, I just came back from India, and some of the hospitals, the national accreditation even have a specialized accreditation for nursing excellence. Like the NABH, they have a special accreditation for nursing excellence. So they look at the hospital to see how are you managing your nurses, your nursing pool, the competency assessments, the empowerment, and then you get accredited for that. So that's an excellent thing, right? So, which means a nurse, when they look for an employment, if they look for an organizations where it has got an accreditation for nursing excellence, and that is something for you to consider. And it may not be available in your country of operation, but I'm sure you can learn from the terms of reference of that accreditation and implement some of those within your organization to see how best I can. So there are many ways of looking and managing at staff turnover rates within the organization. So again, the data comes in very, very useful, but you can see the range is very, very phenomenal here. Next slide, please. Again, day surgery cases, as I mentioned, the reason for the underdeveloped day surgery cases, it's very, very wide again. It could be clinical skill set, the patient profile, and in some of the markets, the patients could be coming from the neighboring region. So, you don't get the same level of post-op care when you go back. So they tend to stay in the hospital longer, 2-3 days until they recover fully before they go back. Or it could be, as I said, it could be a payer-driven issue that insurance companies are not paying for day surgeries. They only recognize inpatient overnight stays. So many different. So again, you need to look at what is that is applicable to your operation, and then adopt and look at that. But this is again a huge room for development and improvement within this space here. But I think this is the key, because the only way to reduce healthcare costs to everyone is to reduce hospital care. So which means that if a patient can be treated at a day surgery setting or an outpatient ambulatory setting, that's a way to reduce costs. Because if you treat a patient in an acute hospital setting, there is an inherent cost associated with that. You cannot bring it down a certain level. So that cost is always there, because your overheads are different compared to an ambulatory care, to an acute care, or a tertiary care. So treating the patient at the right level of care is the most important thing to look at when you want to bring down the overall healthcare burden for the payer, provider, and the patient. So day surgeries is an emerging trend across the globe, even in developed markets. So this is something which can be looked at in much deeper, and there's a huge room for improvement here. Next slide. Quality measurements, as I mentioned, again, we have seen again a wide variation of quality indicator reporting. And as I mentioned, there are certain areas which could be improved, because if you look at, for example, the outpatient falls, people might report inpatient falls, but then outpatient setting, the patient falls are not reported well. So there could be a potential of underreporting there. It could be a cultural thing as well, as I mentioned. If nothing happens to the patient, nothing to report, right? So that's one way of looking at it by some participants, that unless the patient is injured or something fatal happens, it is non-reportable. So it's like a self-screening, they do that. So I think that's a danger, because today's near miss can be tomorrow's fatal incident. So you need to understand how the culture behind reporting. So this is something which you need to encourage within the organizations to report. If you do not report, you do not know where the gaps are, you have less room for improvement. So again, next slide, please. Again, formal accreditation. Again, as I said, this is again, look at common sense, right? Oh, accreditation means you're going to have high level of quality metrics. True, but accreditation, as I always say, it's only a license, right? It's like your driver's license. Just because you have accreditation, just because you have a driver's license, does that mean that there is no more accidents on the road? No, right? Most of the people driving on the road have a valid license, but accidents still happen because you are in a hurry. Maybe there's too much of activity on the road. Maybe you are careless, whatever it is. So accreditation, driving license is one thing, but then your daily operational behavior is totally different thing. So although formal accreditation appears to impact high level of completion of quality metrics, you need to look at consistency of your quality indicators, consistency of ground practices, what your policy says versus what your practices are. So again, that wide range of completion with accreditation, without accreditation, again, there is variation, but then it's also important, look at even with accreditation, how are you comparing versus your own peers within your network versus external bodies, so that room for improvement there as well. Next slide. Again, there is significant improvement in quality measurement is possible. Again, if you look at, and these are comparing repeat participants. So participants who participate in 2023 versus 25. The most encouraging thing is their own reporting has improved a lot, which means that yes, there is potential for even further improvement. So what they reported in the previous round versus how many have reported in this current round, you can see almost every indicator seems to be reported better. So again, this is a very encouraging slide, at least for us to understand that there is great value people see, because people only report things because if you're going to be blindly penalized for reporting, nobody's going to report it. But then if you report it and the management looks at the reports and the data and the comparison and use it to make life better for the staff, the patient, provider, payer, everybody, then there is some merit in reporting. Then it becomes intuitive, more natural. So I think this shows that performance improvement, process efficiencies should be the way to go, so that the reporting becomes meaningful for everybody. Because there's a lot of work to report, there's a lot of work to analyze, a lot of work to validate those indicators. So if you don't make it useful, then there's going to be natural death. But I think in this case, it shows that reporting with the right improvements that comes out of this data makes life easier for everybody and makes it more natural to report. Next slide. And this is again, higher productivity reduces quality. So there is no evidence to show that, because you might think that when your productivity is at a very peak level, when you're seeing more patients, when you're utilizing your operating theaters much more than somebody else, or your number of outpatients per clinic is much more than somebody else, it could drop in quality. It's not true. But if you are very process driven, you measure your processes, protocolize it with right level of training and monitoring and management, higher productivity doesn't have to mean reduction in quality. In fact, it should be beneficial to because they are interrelated. You provide better quality, you get better productivity, you can provide better quality. So there is no correlation that higher productivity means reduced quality. Very, very interesting observations which we have seen as well. Next slide. This was a pilot which we did this time around maternity outcomes, and as I mentioned, they seem to be underdeveloped in many of the reporting which we have seen. It could again be that my guess is that it could be the pilot round, people trying to understand how a lot of things they could be measuring it, but maybe not. But then again, this is not a discouraging set of indicators, but I guess there is again room for a huge improvement in this area. So hopefully in the next round we would see maternity outcome or many of the other clinical indicators which we look at gets better. Next slide, please. Yeah, so this again shows that the variation in the indicators that they have reported, whether it's primary C-section or post-cesarean anesthesia complications. So there is the wide varieties, and then of course we only looked at the entities which is providing 100 deliveries or more to be statistically significant, but huge room for improvement here as well. Next slide. So what we are hearing, this I think is the last slide. So what we are hearing from this is that there's a lot of interest in looking at specific performance improvement areas, the utilization of assets like your operating theaters, the doctor engagement model, as I mentioned. How do you engage with specialists full time versus visiting, and recruit and retaining the workforce? So and people want to look at peer models and comparisons to better their position within the care delivery, quality improvement, HR planning, staffing level. So these are some of the areas which we see a huge interest in performance improvement and process efficiencies. So I think this is very encouraging to see how the data is going to be utilized. Is that the last slide, Jenny? Yes. So thank you again, and I think over to Yana to kickstart the discussion with the rich pool of panels, and hope it's going to be a very useful interactive session for everybody. Over to you, Yana.
Yeah, and we thank you, Raju. This is great. I understand that we dumped quite a bit of data onto you. Yes. Don't worry, we will share all the slides within 1-2 days after the session. So I will actually introduce our panel. So we have quite an interesting panel for you. So we have the pleasure of having Leona Karnali, who is CEO of Primaya Hospital Group in Indonesia. We also have Dr. Mustafa Metin, who is Chief of Staff and International Business Development Director in Koç Healthcare in Turkey. So different geography, but also very interesting market. And we also have Kusnadi Pradinata, who is Senior Managing Director in Growthium Capital Partners. So who can represent the fund, the PE fund that managed by Kusnadi, invested in healthcare assets, and who participated in our benchmarking. So Kusnadi can represent the investor point of view. So we have diverse backgrounds, diverse regions of coverage. And perhaps I can start with a question to Leona and Dr. Mustafa on why you have decided to participate in IFC Healthcare Benchmarking, and what has directed you to this, what has interested you into this project.
Shall I go first? Hi,
Please.
everyone. Thank you, Yana. Hi, everyone. I'm Leona Karnali. I'm from Primaya Hospital Group. So a bit of context, Primaya Hospital Group, we are a listed private hospital group consisting of 20 hospitals across Indonesia. We have a total of 3,000 hospital beds with 7,000 employees and about 1,500 specialists. We are one of the first private hospital group in Indonesia that accepted government insurance or universal health coverage patients. So why benchmarking? So first of all, data is scarce in Indonesia, and we need references in setting our target and knowing our position in terms of our performance, especially the operational metrics. Because we're a listed company, we do have some benchmarking in terms of financials, but in terms of operational metrics, it's really difficult for us. So we are really interested in benchmarking because of that. But other reason, in order to improve quality, we do need benchmarking against other hospitals that are similar to our hospitals. And as Raju mentioned earlier, it's really difficult to get those data, and being able to participate in the IFC benchmarking really help us to understand where we are, and how we can improve. So, and last thing, besides quality, we also need a benchmark for clinical outcomes. In this case, IFC benchmarking also provide those. So that's from me. Go ahead, Dr. Mustafa.
Thank you. Welcome, everyone. Just as a little introduction, as Koç Healthcare Institutions, we represent 13 private hospitals, one being an animal hospital with more than 8,000 employees in Turkey. And we have a huge dedicated international patients program where we welcome patients from across, I think, 150 countries in a given year. And we are in a phase of rapid global expansion to a different market. So a global benchmarking study was critical for us at this stage. Internally, of course, we already measure hundreds of key performance indicators for different department needs or clinical outcomes, or sometimes it's a system-wide KPI. But the real value I think IFC delivered was not collecting more data for this, just for this study, but you know about the organizational blindness. Sometimes you need an external perspective, and I think this benchmarking study have provided that external review or fresh eyes on the data that we already have, and to see how we are performing internationally rather than only in our local market in within Turkey. As I have mentioned, with global expansion plans, we have a lot of assumptions that go into our feasibility studies based on our performance in our own local market. But we wanted to see and validate if our assumptions have assumptions that went into our feasibility study before making big operational or investment decisions as well. So IFC benchmarking study overall have delivered, I think, on these what we were looking for.
Yeah. Thank you so much. My next question is, what was your key surprise or key insight from this round? And perhaps we go to Kusnadi first on this one. So,
Yeah,
Kusnadi,
hi.
what surprised you, if anything?
Yeah, so maybe a bit of background. So my name is Kusnadi. I am from GCP. So obviously, it's a private equity based in Singapore. We have had a 3-year partnership with a family out in Cirebon. Our partnership is in a universal healthcare focused hospital called Mitra Plumbon. The biggest thing for us was, I think it was just out of the study, is really the confirmation. So when we first invested in Mitra Plumbon, we had this belief that with our partner, they can run a hospital in a country like, say, Indonesia and have it every bit as good as one in a developed country, right? But I think belief is probably one thing. But what this exercise did was to put a real number, I think, next to it, right? And there it was. I think what we think is Mitra Plumbon's profit and returns all sitting right next to the big hospital group in a developed country, except we probably charge our patients at a fraction of what they charge, right? And really, I think what genuinely surprised me, and I didn't really expect this going in, was how many things other than the day-to-day management that drives the numbers, right? It's how established a hospital is, what the local market looks like, who's paying the bills, right? I think the benchmarking is pretty clear that the differences between a hospital can come from a mix of all those things, right? Not just how well a place is run, right? So as an investor, the real lesson for me is you have to work out which part of a hospital strong number is really the team that has been genuinely excellent, and which part of the situation is just happens to be where it is, right? Because those two things, are worth very different things when you're buying.
Thank you. Thank you. So for you, it was confirmation and seeing the next, seeing the hospital, the investee data next to the others. Leona, what was it for you in terms of insight, or what stayed with you out of all the 40,000 data points that you had the pleasure to review.
Yes, I think the good thing about the IFC benchmarking, we can really see the data. So we can slice and dice of the 144 variables or measurements that we have in this benchmarking. So we can utilize it depend on our needs. So that's really helpful. What's surprising to me is really all over the place. I agree with Kusnadi. We do also have confirmations in some cases, like for example, the staff turnover, because we have targets that we want to achieve on the staff turnover. Some hospitals can do better, even lower than 10%, but we can see that where the median is, where the average is. So that's really helpful. But what's surprising me also in terms of mixed patients, I can see that a lot of patients are still doing self-pay. I'm talking especially in terms of the region of Asia. So that's also part of the benchmark that I can use for our marketing team, especially in terms of self-pay, private insurance for and corporate, as well as the government paying. And another thing about the clinical outcomes, as well as the quality, in terms of ICU, intensive care, for example, we can do so much better in terms of the quality care there, especially. I think that really helped. That really trigger us to do a specific program to improve quality in ICUs.
Okay, thank you. Mustafa, your surprises, if any?
Yeah, of course. I think all of the panelists have mentioned about the confirmation. It was particularly same for us. But one thing that stood out, I think Raju has already underlined, was the variation across the international hospitals internationally, where there you see maybe 5 times variation across utilization on the same clinical area. And to be honest, we also saw some variation within our organization, within our hospitals as well. We of course compare the KPIs across our institutions, but more so on the financial results and financial metrics, but not always the case for the operational metrics. We do not have a singular business model or a pricing strategy or patient segmentation for all of our hospitals, as we are in different geographies. So we needed to examine some of our differences, variation across hospitals. I think one important insight was about our quality metrics, and we had a significantly very high number of reported incidents per bed for all of our institutions. So immediately, of course, our upper management raised the concern if this was a sign of poorer performance. But looking at not only the number of reported incidents, but examining the whole quality assurance or quality management metric data, we saw it was more about the strong reporting structure or improvement culture and transparency regarding those near misses. As we saw, mortality rates or hospital-acquired infection rates were significantly lower than the average, where we compared the reported incidents were significantly higher. So we tell to our clinicians, or all the members of the care, that you cannot improve what you don't identify. So that was an important confirmation with the benchmarking study. And we had also one more thing about the staffing levels and the staffing cost as percentage of your revenue. I think that was also significantly higher. We knew about this with our staffing levels. For our competitors, we have higher clinician or nursing rate per patient, but that is closely correlated with our business model. We don't see that as an underperformance, as we are a reference center for complex surgeries cases, diagnoses, cancer cases, and that needs higher staffing levels or top-tier doctors. And that also actually helps us deliver better patient outcomes. So although we were definitely outliers on those couple of the metrics, that was a reminder of our core principles of our business and business model.
Okay. Thank you, Mustafa. And actually, when we see high number of incidents and near misses, we are actually not that worried. We are worried when it's close to zero. Then if incidents are close to zero, and especially near misses, then it's a red flag, which I would recommend everyone to do. And so you have heard about various parameters and so on, but perhaps I would like to ask Raju to reflect, because benchmarking is not intended to be a league table. Yeah. So what's the good use of benchmarking data and what's not so good use of benchmark, like where you can make it useful, perhaps throughout the all interactions with all our partners and your experience as well. Yeah. So how would you recommend? Some benchmarks have been released through this presentation. How would you recommend that others can look at it?
Yeah, I think that's a very interesting question, Yana, because as I always mention, benchmarking doesn't give you all the answers. I think that's something which you need to understand. But what it does, it helps you ask the right questions. So I think you got to differentiate that. It's not the answer. It helps you ask the right questions, because usually what people do is you tend to compare the most visible features, right? Because without understanding the underlying systems, I touched upon that, because when you look at a hospital with 200 beds, 50 ICUs, doing a certain performance in terms of financially, whatever, you think, okay, that's the right model. Let me do a 200-bed hospital with 50 ICU, but I should be able to make the same amount of financial returns. Well, that's a visible feature, but you need to understand what is driving that hospital performance. What is their specialty mix? Why do they need 50 ICUs versus 15 ICUs? Maybe their specialty mix is highly surgical. I do not know. Maybe their patient mix is very different. Maybe they have a very active emergency and trauma center that is driving the ICU volume. So I need to understand the underlying systems behind indicators, not just the visible features to come. So this is the danger of benchmarking blindly. Then it becomes an imitation, not insight. You just imitate somebody and then thinking that I should do the same way. But I think, and again, and I touched upon some of the indicators, like when you look at utilizations, why is utilization for somebody better than mine? Could be, as I mentioned, you got to understand the interdependencies of the indicators. I think if you don't understand the interdependencies and compare blindly, that's where the danger is. So benchmarking helps you ask the right questions. It doesn't give you all the answers. So that would be my advice to the participants. Yeah.
Mm-hmm. Asking the question. So can I ask each of you to, and you mentioned, but perhaps you can say which, let's say, 1 or 2 or 3 questions that you asked of yourself, or how have you used this data or this approach in the follow-up after the benchmarking? If you can give an example, perhaps one example from each of you, that would be great. Mustafa, can we start with you?
Yeah, I can start. I think the initial reaction was we identified what were like some of the where we differed significantly on some of those metrics. And I think the initial question was, is this intentional? Are we intentionally performing in where we are on those benchmarking studies? And in some cases, like even though it is considered as an underperformance, we don't necessarily see that in that way. For example, if you're promising a same day, next day, same week appointment, surgery, or an imaging study for your patient, if that's your unique selling point, I don't think you can have 100%, 90% capacity or utilization rate, because that's what drives the patients to your organization for a timely access to care. So if you see that like 90% is an underperformance for our business model, that's an intentional decision. So we asked if that bracket or if where we are on the benchmarking study is intentionally decided or not.
Okay, intentionality. Yes. So okay, Leona, if you can also give an example from Primaya Group. How have you used it?
Yes. So after looking at the data myself, and also a summary from IFC is really really helpful for our group. I shared the results to our hospital directors, so 20 of them, as well as to the medical heads, because I want to emphasize on improving quality, especially in the clinical outcomes, and also related to medics. So we gather together, and actually we look at the results based on the PowerPoint that we get from IFC, and I can see the reactions from the directors and the hospital medical heads, where they should improve and where they actually good at, and also boost motivations from the team to actually, oh, so we are actually doing okay. For example, like staff turnover that has been like really concerned of many of us, but then when we look at the number, oh, actually we're still doing okay. um and that help us in terms of motivation, but when we see the utilization, oh no, the utilization is so low in terms of CT scan, MRIs. Yeah, we can improve a lot more. But understand, I mean, it's understanding. I mean, understandably, because we are a growing hospital. A lot of our hospitals is under 5 years or 10 years, so they're still growing and ramping up. But they know where we want to get, or the target, and for the hospitals that has been stabilizing, they can also stretch their target based on the data that they have looked. So that really helps in that way.
Okay.
I think for me, from a private equity standpoint, totally agree with Dr. Mustafa and also Ibu Leona. But I think the way that we use this data is to, again, as a confirmation that we are really backing a really well-run hospital, right? So what I would say is that for us in Mitra Plumbon, the everyday workhorse part of it, I mean, like the operating theaters, the bed, the maternity ward, the dialysis unit, the outpatient clinics, these are all like running busy and full, right? Probably I would say among the best in the whole group, right? But I think where it really gets interesting and useful for us is the next step, right? The data really shows where there is still room to grow, right? With Dr. Mustafa and Leona, right? So the more highly specialized, higher end services like the heart care, the cancer treatment, the advanced scan, which aren't really as busy as they could be, right? But again, as all participants are, we really see it as more of a runway and room to grow. So our job as the owner is to put investment and the right doctors behind those services, right? And the more the hospital treats more patient, it earns more. I think those two go together. But let me give you a real example, right? Say, for example, we have always suspected that, but now we could clearly see is our everyday services were running full, but our high-end equipments, right, the heart cath, lab, the cancer treatment, the MRI scanner, were really much quieter than it should be. So then the question that we asked is the obvious thing is, we went in and we asked, is that the patient aren't coming or that we don't have enough of the right specialist doctors to handle them? So there's a lot of questions internally, but that one number turned into a proper piece of work, right? That we can, instead of looking at our specialist lineup, the referral patterns, it's not really shaping into where we should put our focus and the investments going forward, right? I know it's early, but I think for now the
Yes.
real thing is that so far we have clarity, right? Instead of trying to guess here and there. And we
Yeah.
discussed this a lot with our partner, Dr. Festus, right? And Ibu Saraswati as well.
Yeah.
And I think Kusnadi, one more thing from your operations, which I also noticed is that when you do a very high percentage of social health insurance, but still the hospital's profitability and everything is very phenomenal. So I think that's a lesson which others could also learn, because it's always a perception is that if your social health insurance, your receivable days is going to be terrible. You can't run a sustainable operation. So I think your example actually shows that doesn't have to be the case always. So I think there are certain lot of lessons which we could learn from looking at the data and the insights as well.
Absolutely, Raju. Yeah.
Yeah.
Yeah. Changing gears a little bit. So in 2025, we also piloted the maternity outcomes benchmarking. And benchmarking clinical outcomes is super difficult, as you know, like all the risk adjustments, conditions. So it was our first trial. And as Raju has said, we got two things. First, well, not everyone, well, 60% were not able to share clinical outcome data, unfortunately. But nevertheless, some distribution on we were able to get, and we were able to get to see who are the lowest tracked, who are the top performing, top performing, let's say, lowest quintile or lowest 5% in terms of best result, which provides an indication on what's the level of achievable practice. So question, and perhaps I can ask Leona to reflect first. What do you think could have been behind the somewhat lower level of data submission, and how, by just seeing this what to measure, but then also this best benchmark, how it's possible to influence and strive to achieve better clinical practice? If you can start commenting.
From our group, out of the 20 hospitals, right? We have 5
And you did very
hospitals.
well, actually. I recall that Primaya was one of
Yes.
yes, of those who did provide the data. And so if you can reflect on reasons behind others, yeah.
Oh, I may not know what's the reason behind others, but of course, sharing clinical data could be a very sensitive thing to do, because don't know what to expect. But for my team, because I encourage them to share, so we can help the benchmarking, and we can also get the numbers. I mean, to reflect on ourselves. And quite surprisingly, we do surprise with the the data that we get from that exercise. I think the maternity, I mean, we start with the maternity, which is very crucial, right, for any populations to have these clinical outcomes right, or better. So I think this is a good initiative from IFC, that has been done and should continue going forward. I think as time goes by, people will hopefully participate more on this data and understand the benefits of having this data, clinical outcome data.
Okay. Anything to add from anyone? Dr. Mustafa or Raju?
Yeah, I can add. I can provide a different perspective. We believe that that's actually a great area to compare, or benchmark. But I will be transparent. We were one of the institutions that hasn't submitted a lot of the maternity outcomes in this round. And I linked that. I think one of the biggest challenges in there, I think Leona has mentioned, is collecting standardized like clinical outcomes data is much more, like significantly more complex than collecting any financial outcome or operational metric. You need like clear definitions. You need to have consistent documentation across all of your providers or caregivers, and have a robust data governance structure. I think that was one of the reasons where participation was lower than expected for that specific subset of questions. And we do realize like women's and children's health service line is a key growth engine for the entirety of the hospital. So it's not the lack of interest in those like metrics, but rather having all of those like clinical outcome data ready even before participating in a benchmark study. But that's the
Yeah.
key lesson that we learned, and we will be hopefully providing those on the next round of benchmarking.
And by the way, for everyone's benefit, we would put this different explicit definitions of the indicators, what goes to nominator, denominator, what are exclusions on the website, or you can email to us, so that what Mustafa says, like you can start tracking already now and even compare with the last year's published results, or be ready for the next rounds of benchmarking to come. So that it's more measured, and then in case you're not pleased with the level of your performance, then you're able to address it on a timely basis with the clinical team. We have quite interesting questions in Q&A section, so let me get to those, because I think they will add to discussion. So questions come from Vietnam, and I would take them one by one. Your perspective on what are the key value creation and valuation drivers that distinguish leading hospital chains in emerging markets from their peers, and how do investors typically assess the balance between growth, profitability, capital efficiency? Raju, perhaps I can first come to you, then Kusnadi, and then we'll see Leona and Dr. Mustafa if they can add. So key value creation and valuation drivers from investor perspective.
Yeah, but I think before I pass it to Kusnadi to have an expert opinion on that, I think from my perspective, I think when you look at key valuation and growth, again, you need to understand the drivers behind the growth and the valuation, because every valuation and growth projections look excellent on Excel spreadsheet, that's for sure, right? There is no analyst going to give you a spreadsheet that says the growth is not happening. So I think that is there, but they need to understand the drivers behind what is really going to be driving the growth. And then I think that would be the key for investors to understand. And that's where sometimes this data comes in very, very handy, because somebody is projecting a certain projection of growth in a certain market with comparable data within that market or the micro market. As an investor, you will be able to see, is that an achievable growth factor? Is that projection reasonable and realistic? And then that could basically help you to assess correctly and value the investment opportunity correctly. Over to you, Kusnadi, for some practical insights.
I think when it comes particularly with Mitra Plumbon, right, what we have, obviously, as Raju mentioned, Mitra Plumbon is predominantly a universal healthcare focused hospital. And I would have to say that our partners, Dr. Festus and his family, have done extremely well as very efficient, of SaaS and operator, right? It is mostly in tier 2 and tier 3 cities, but the way that we look at value creation is down to making sure that, because we are operating within that constraint of a universal healthcare, cost efficiency, whether that comes from drugs, that comes from equipment, that comes from procurement, that comes to make sure that we are turning our beds, appropriately, right? So all of those are key factors for us. But more importantly, I think is this whole culture, this whole culture of being cost efficient, and I think it really to be. We are truly blessed when I'm said that, we have a great partner, because it is an owner and operator mindset. So as an owner and operator, you really instill that mindset and that culture across, and it permeates across the entire institutions, right? So I think that for us was a key thing. The next value creation for us is that now that we have established a pretty good blueprint that we can effectively copy it across multiple sites, right? As we expand forward, we are trying to now increase the revenue intensity going forward. And what I meant by that is that not every site, not every hospitals will be created equally. So in certain sites, it's more matured, and we're starting to think about which specialties we should focus on and try to increase the revenue intensity and also the complexity within that hospital, right? Along with that, while we are a universal healthcare focused hospital, it doesn't mean that we can't service a private patient in those tier 1 or in the tier 2 or tier 3 cities. So we're beginning to also tune up our hospital to make sure that we are equipped, right, to be able to service those private patients as well. So one example is, As you know, Raju, we have got JCI accreditation, right, for one of our hospitals, right, in Cirebon.
Okay, thank you. Dr. Mustafa, Leona, anything to add on the value creation drivers?
I can
Yeah,
just, I'm sorry, go ahead, Leona.
go ahead. Oh, okay, thank you. So actually similar, yeah, with Mitra Plumbon, for Primaya hospitals, we have to come back and see what's the purpose of our hospital group. We have to come back to our vision and mission. We want to be a hospital group that is inclusive, and we want to make healthcare affordable. So of course we need to balance between profitability and growth, because we'd like to bring access of healthcare to Indonesian people as much as we can, and yeah, as much as we can in terms of capital and financing and etc. So I think yeah, there should be a balance depending on the value that you want to create actually.
Okay, Dr. Mustafa.
What I can add is I think healthcare delivery is extremely complex, and even I've been in the business for more than 10 years, and I sometimes feel lost with all the trends and all the operations complexity, and I cannot imagine for the patient. So when we were thinking about delivering value, when a patient initially receives their cancer diagnosis, they feel completely lost. So we decided to create those service lines and centers of excellence. I think that was the second part of the question, so I wanted to address that. So for, let's say, breast cancer, we have streamlined and a patient flow. So the patient will be seen by the general surgeon, the plastic surgeon, the oncologist within the same clinic, and there will be the mammography device as well. So the streamlined patient experience, I increase the utilization rates. And the other aspect is, I think, building the capacity. Oh, sorry. You can hear me? Yeah.
Yes, we
And
can. We can. It
also,
was a little bit interrupted, but it's okay.
sorry.
You're
Okay.
audible. Yes.
And the other perspective I can offer is building the capacity before the demand arrives. Like if you have not, I think, invested on geriatrics or managing chronic disease, I think you're already late. Through like the digital systems or remote patient monitoring capabilities, because we will not have enough resources, enough staff to manage the great tsunami coming. So you have to build a little bit before the demand arrives. And I think that's a key thing, and that's the key leverage point for the successful hospitals in the emerging markets.
Okay, very interesting. And for the benefit of listeners, I'm reading the second part of the questions, which to which Mustafa has been. It was about hospital change in emerging markets and the development pathway that has proven most successful in creating long-term shareholder value, either rapid network expansion through the facility, operational excellence, efficiency improvement, development of specialized centers of excellence. So the question was how management should prioritize this initiative at different stages of growth to maintain the balance of maintain the balance and define actually the strategy. So that was the question. Mustafa shared his perspective, but Leona or Raju or Kusnadi, anything from you on the centers of excellence or strategic choices for sustainable success, I can say.
I think maybe I can quickly say that if you look at the overall trend of where healthcare delivery is moving in emerging markets or across the globe, is that, as I mentioned in my insights earlier, that look beyond just hospital care, look at creating that ecosystem and treat the patient at the right level of care. And that's where things like ambulatory care or day surgery care, out of hospital care comes in very handy. And this is where you can look at the data and the insights as well, because treating a patient in a hospital setting has got a certain cost to it, and you can't bring it down. And so if you want to reduce the overall financial burden for the payer, provider, and the patient, treat the patient at the right level of care, preventive care, outpatient care, ambulatory care, and then tertiary care, and beyond tertiary care, long-term care, step-down care. I think overall, and so as providers, investors, and that's what I would encourage people to see and combine this with universal health coverage, better use of funding. Everything fits in very well here because not everyone needs hospital care. So I think that would be my key message to the participants. Yeah.
Okay. Okay. Kusnadi, do you want anything to add to this?
Yeah, maybe a quick one, a short one, and I would completely agree with Raju. I think for us, in the context of Mitra Plumbon being predominantly a universal healthcare, we have altogether roughly about 7 hospital operating. By end of the year, we'll probably have another 3 new hospitals coming up. Different hospitals are at a different journey. Right. So for one of our older, more established, that would probably we're thinking about center of excellence. But for the younger ones, I think the key ones really would be more about efficiency improvement and also operational excellence. I think those two have to go hand in hand, right? Again, but overall, I would think that on a long-term basis for shareholder value, that a particular site or hospital is only limited to has a natural catchment area, right? So to create that long-term shareholder value as we continue to create that revenue stream, we would have to expand our network expansion. And if you look at the way that we have done in Mitra Plumbon is that it's almost, I would think that almost like a web, right? Where you have a hub and a spoke, right? And then where the hub, becomes your center of excellence. And then over time, some of this spoke will then become your hub, right? Or your secondary hub or your tertiary hub. That's how we would think about that.
Okay. Thank you. We are actually out of time. There were a few more questions, but we perhaps can follow up on them through chat. I would like to finish with a simple question. Some benchmarking data would be shared with all the participants, but if a healthcare provider would like to turn some of this benchmarking shared insights into action next month, what shall be their first step that they should take and why?
Maybe I'll start first,
Yes,
Yana.
please.
I think the way that I think about it is that there's so many things that you can try to fix, right? But the way that we work with Dr. Festus and his mom is really don't try to fix everything, right? You pick the one thing where you are really behind the best performers and where you can realistically catch up, right? And I would think that not probably the most broken thing, but the most fixable thing, right? So you put one person in charge of it, you check the number again, let's say in 3 to 4 months, and just measuring something and watching it, I think it's already a first improvement, right? And I would think that usually a one small win gives people the confidence to tackle the bigger one, right? And I think that's exactly what we did here at Mitra Plumbon. We didn't try to chase, everything at once. We picked the one area with the real, room to grow, right? And put all of our attention in there. And that's really become the template for how we work with the hospitals, right? We start with one, we prove it, we move it, and we then go again. Again, as I said, I want to stress again, the owner operator model and the obsession, with efficiency, it really does help. And again, our Dr. Festus is also very data driven, very data analytics, right? So that really helps out my job, a lot easier.
You're on mute, Yana.
Oh,
Yes, I was saying just pick one, solve it, move to another. Shaliza,
Yes,
I see your
thank you,
hand.
Yana. Thank you so much. So I'll be speaking on the perspective of who helps prepare these projects, these investments, the greenfield, and also coming in when some restructuring is needed, right? So picking up on Kusnadi's point on efficiency and maxing out your existing assets before thinking about, okay, what's next? And making sure that capacity utilization is indeed very much maxed out, because according to the benchmarking report, there's some overwhelming numbers that demonstrate that if the capacity is efficiently utilized, you can treat 9 million more patients. So that's very impressive, right? So I think that understanding where are the issues, where are the gaps, and really tackling in-house those efficiency metrics is key, at least when we look at investments and thinking through how to support our clients.
Okay, thank you. Leona and Mustafa, your last words to participants, what to do next month to prepare either to improve themselves or to prepare to the next round of benchmarking.
I completely agree with Kusnadi. Picking out like small number of high impact indicators to improve is critical to motivate the rest of the team as well to work on the rest of it. I would like to highlight the importance of multidisciplinary team working on those indicators. It's not only finance team or operations team, quality team that will work on a single performance indicator, but it should be a multidisciplinary approach. And you have to, as a physician by training, you have to include the clinical team as well. They will be providing critical feedback from the front lines. And what we have also established is a patient and family advisory council that sometimes, if it's relevant, bring the problem or the metric that we would like to improve to that council and gather their feedback, first-hand feedback from our patients and families as well.
Okay. And Leona, you would be the one to.
I agree with everyone. We need to prioritize in terms of improvements, of course. And I think there's a lot of data that we can still look at and analyze as well, and be prepared for the next benchmarking.
Yes. Okay. So to sum it up, dear participants, so benchmarking can be powerful to confirm some of the trends that you are aware, to get external view in terms of in a balanced way on how things are. And most importantly, ability to question yourself on, am I satisfied with this performance, or it's okay, it fits my business model, or no, this is one of the few critical things that we want to prioritize and improve it. And as we have, and it's another step in progressing for all healthcare facilities in improving the excellence of healthcare service delivery and treating more patients and treating patients for better clinical outcomes. I would encourage everyone to, we will share the presentation. We will also share the template for maternity outcomes. And I would encourage for the next round, which would be launched sometime in 2027, to participate as well, but benefit from the data that we share already now. Thank you so much, and thank you for panelists. This has been great. I totally enjoyed the discussion. For participants, please fulfill the survey on exit and indicate which further topics might be interesting to you. Thank you.
Thank you.
Thanks, everyone.
Thank
Bye.
you all.
Bye.
Thank
Thank
you.
you. Bye.